Today, we are opening the door to what has to be the body's most complex and beautifully orchestrated communication network, the endocrine system.
It really is. I mean, if you want a shortcut to truly understanding how the body maintains balance and what happens fundamentally when that balance fails, this is the conversation to have.
I like to think of it this way. The nervous system is the body's internet instantaneous electrical signals. Then the endocrine system is more like a highly organized, very precise postal network.
That's a great analogy. It uses these scattered glands to secrete hormones, which are basically chemical letters that travel through the bloodstream to act on really distant targets. It regulates all the big, long-term stuff: growth, metabolism, our entire stress response.
Okay, so let's unpack that communication idea right away. We say endocrines, and we mean those hormones that travel, globally through the circulation. But there are smaller, more local conversations happening too, right?
Oh, constantly. You have what are called paracrines. A cell releases a chemical and it acts just on its immediate neighbors. It's like a quick whisper across a desk.
And then the third type.
Autocrines. That's when a cell releases the substance that acts back on itself. It's essentially a self-check mechanism. Little note to self.
So it's a multi-layered system. And that brings us to our mission today, which is, I think, pretty ambitious. We're going to use our extensive source material. We have detailed medical text, some fantastic physiological diagrams, and crucially, the actual visual evidence from pathology slides.
The H&E stains, the gross specimens, the real proof.
Exactly. We want to understand not just the definitions of endocrine diseases, but the underlying pathology, the genetics, the clinical picture. We're diving deep into the pituitary, thyroid, parathyroid, pancreas, and the adrenals.
And our source material really is like an expert guide, giving us the literal microscopic signature of what failure looks like. So the core question we're tackling today is this: how do these tiny, scattered organs manage the entire internal landscape of the body?
And what are those specific, undeniable visual fingerprints that pathology gives us when that delicate chemical balance finally snaps?
That forensic approach is what makes this so fascinating.
I agree. Let's start at the top then, at the master control room, the small but incredibly mighty boss of the entire system.
We're starting with the pituitary gland. It's this tiny, bean-shaped structure, but it is absolutely central to everything. It sits perfectly protected, nestled in a little bony cradle at the base of the brain called the sella turcica.
Right below the hypothalamus. And its small size completely belies its importance. Its entire function is dependent on that connection to the hypothalamus through the pituitary stalk.
It is. And our source makes it really clear that the gland is functionally divided into two completely distinct parts. You have the anterior pituitary, which is glandular tissue, and the posterior pituitary, which is really just an extension of the brain's nervous tissue.
The anterior lobe, the adenohypophysis, that's the real factory floor, isn't it?
That's the factory, yeah.
Yeah.
It's made up of 6 major cell populations, all coming from these multipotent stem cells. And we classify them by the hormones they secrete. We have somatotrophs for growth hormone, or GH lactotrophs for prolactin, PRL.
Corticotrophs for ACTH, thyrotrophs for TSH, and gonadotrophs for FSH and LH.
And then you have what are called null cells, which don't really stain for any specific hormone.
I think the mechanism behind how they're classified is a key insight here. You mentioned transcription factors in our prep. For the listener, why does it matter that a somatotroph, for instance, expresses something called PIT1?
It's fascinating because that transcription factor, whether it's PIT1 or TPIT or SF1, it acts like the cellular director. It tells the stem cell what its lineage is going to be, which type of hormone-producing cell it's destined to become.
And that's important for disease.
Hugely important, because when tumors arise, they almost always retain the expression of these factors. So we can classify a tumor by its transcription factor, say PIT1. We know exactly which family it came from and which hormones it might be producing, even if the staining is really subtle.
This level of control is laid out beautifully in one of our core visuals. It's figure 24.2, which illustrates that exquisite feedback regulation of the anterior pituitary. The hypothalamus isn't just a facilitator, it's the ultimate commander.
Absolutely. The hypothalamus releases these stimulating hormones like TRH, CRH, GHRH, but also, and this is crucial, inhibiting hormones.
Like dopamine, which inhibits prolactin.
Exactly, and somatostatin, which inhibits growth hormone. These messengers travel down the pituitary stalk through this very specialized portal vascular system, and they either hit the gas or hit the brakes on the 6 major anterior pituitary hormones.
So those hormones, ACTH, TSH, GH, and so on, they're then released into the general circulation to act on their target glands, the adrenals, the thyroid, etc. And here's the key to the whole balance. Once the target hormone level gets high enough, it exerts negative feedback.
It sends a message back.
Right, it signals back to both the pituitary and the hypothalamus to say, okay, that's enough. You can stop releasing the stimulating hormones now.
It's just like a thermostat in your house. The house gets too hot, that's too much hormone, and the thermostat, which is the pituitary and hypothalamus, turns the furnace off. It's a system that ensures stability.
Now let's talk about the other half, the posterior pituitary, the neurohypophysis. This part is different. If the anterior lobe is the hormone factory, the posterior lobe is more like, what, a storage and shipping center?
That's exactly what it is. The hormones it secretes, ADH and oxytocin, aren't actually made there. They're synthesized in the cell bodies of neurons way up in the hypothalamus.
And then they just travel down the nerves.
They travel down the axons that extend through the pituitary stalk, and they're secreted directly from the nerve terminals in the posterior lobe into the bloodstream.
That functional distinction is so important. ADH, or antidiuretic hormone, is the body's primary volume regulator. Its whole job is to conserve water, to stop the kidneys from losing too much.
Right. And oxytocin is famous for promoting smooth muscle contraction. Most notably, uterine contraction during labor and milk ejection during lactation.
And as you can imagine, even a slight imbalance in these two posterior hormones can cause immediate, really significant fluid and electrolyte problems, which brings us straight into pituitary disease.
Clinically, these diseases really fall into two main camps. You've got the trophic effects, which is either too much or too little of the hormones themselves.
And then you have the local mass effects, which is just the physical expansion of a tumor or a lesion inside that tiny confined space of the sella turcica.
When we talk about deficiency or hypopituitarism, it requires a lot of damage. Our sources note that you have to lose something like 75% of the anterior pituitary tissue before you even start to see clinical symptoms.
And the causes can be anything from tumors, surgery, radiation, to something called ischemic necrosis.
Right, and that ischemic necrosis is particularly dramatic after childbirth. It's called Sheehan syndrome. During pregnancy, the pituitary gland actually gets bigger, and if there's a severe obstetric hemorrhage, the gland becomes incredibly vulnerable to a lack of blood flow.
So the tissue dies.
The tissue dies, and the symptoms of hypopituitarism can show up months or even years later.
Meanwhile, the mass effects are often the very first sign of a problem, especially with a tumor that isn't making any hormones. An expanding lesion pushes upward, and it often compresses the adjacent optic chiasm,
Which is where the optic nerves cross over.
and the result of that compression is this very specific type of vision loss, bitemporal hemianopsia, a loss of peripheral vision in both eyes. The patient feels like they have tunnel vision.
And, of course, headaches. The pressure builds up in that confined space.
But the most catastrophic mass effect has to be pituitary apoplexy.
Oh, that's a true medical emergency. It's a sudden, acute hemorrhage into the gland, almost always within an existing adenoma. The patient presents with what's called a thunderclap headache, rapid vision loss, and potentially fatal cardiovascular collapse.
Because of the acute loss of ACTH, right? The adrenals just shut down.
Exactly. No ACTH, no cortisol, it's a crisis.
But focusing back on those posterior pituitary hormones, the ADH issues they're immediate. Deficiency of ADH causes diabetes insipidus.
Which means the kidneys just can't retain water. The symptoms are dramatic. We're talking polyuria excessive urination, sometimes up to 20 liters a day.
20 liters, that's unbelievable.
And as a result, polydipsia, this intense, unquenchable thirst, the patient is at risk of severe dehydration and high serum sodium.
Conversely, you have SIADH, syndrome of inappropriate ADH secretion, the opposite problem.
Way too much ADH. The excess ADH causes massive water retention. It dilutes the blood, leading to hyponatremia or abnormally low serum sodium. And unlike diabetes insipidus, these patients are often volume expanded, overloaded with fluid.
And this syndrome is often linked to cancers, right? Like small cell lung cancer producing ADH on its own.
That's one of the classic paraneoplastic syndromes, yes.
So let's move into the real pathological core of this section, pituitary adenomas. These are benign tumors, and they are by far the most common cause of hyperpituitarism.
And our source material is very meticulous about classifying them. The first thing we have to pay attention to is just the size.
The 1 centimeter threshold.
Right. If it's under 1 centimeter, it's a microadenoma. If it's larger, it's a macroadenoma. And functionally, this matters. The smaller tumors often present early because they're making too much hormone. A tiny polactinoma causes symptoms very quickly.
Whereas the larger macroadenomas, especially the non-functional ones, they often present much later, and it's purely because of those mass effects we just talked about. The vision changes, the headaches.
What about their origin? Most of these are sporadic, But the source does highlight some specific genetic alterations. Tell us more about the GNAS mutation.
This gives us such a deep conceptual insight into cancer. So the GNAS gene codes for a part of the G protein. Now, if you think of the G protein as a critical signaling switch inside the cell.
The on-off switch.
Exactly. The GNAS mutation jams that switch permanently in the on position. This causes constant unchecked activation of the signaling pathway, leading to nonstop cell proliferation and hormone production. It's like a stuck throttle on a car.
And we see that most often in the growth hormone-secreting adenomas.
That's right, which makes the pathology, the visual evidence, all the more critical. Let's look at the morphology, starting with the gross specimen in figure 24.4. What are we seeing when we look at a macroadenoma?
Grossly, it's a soft, well-circumscribed mass. But what's really striking is how it's distorted the anatomy around it. You can see the tumor extending upward, breaching the protective diaphragm of the cella and pushing right into that suprasellar region.
Which is the physical cause of that optic chiasm compression.
Exactly. And now for the microscopic fingerprint from figure 24.5, which is what's crucial for distinguishing it from normal tissue.
The microscopic view gives us the critical diagnostic clue, and it's something called cellular monomorphism.
Explain what that means.
Normal anterior pituitary tissue is a mixed bag. It's a heterogeneous collection of different cell types all mixed together. But an adenoma, because it's a clonal growth, is composed of a uniform population of polygonal cells, all looking the same, arranged in sheets or cords.
But the true distinction, the pathological hallmark, is the absence of a reticulin network.
Okay, for our listener, explain the significance of that missing reticulin network.
The reticulin network is this delicate, web-like scaffolding of connective tissue that structurally supports all the normal endocrine cells. When that network is gone, it confirms that the cells have lost all their normal structural organization. They're proliferating pathologically as a uniform clonal mass. That's the smoking gun for an adenoma.
Let's move to the specific functional types. The prolactotroph adenoma, or prolactinoma, is the runaway winner, right? About 30% of all cases.
It is, and the clinical presentation is very memorable. In premenopausal women, the excess prolactin suppresses the reproductive axis, leading to amenorrhea, loss of menstruation, and galactorrhea, which is inappropriate milk production.
In men, though, or postmenopausal women, the symptoms are much more subtle. Decreased libido, maybe? They often present much later because of mass effects, because the tumor is just discovered later.
What's so unique about prolactinoma treatment is how incredibly effective medication can be.
Yes, because prolactin secretion is primarily controlled by hypothalamic inhibition, specifically by dopamine. So these tumors are often exquisitely sensitive to dopamine agonists like bromocriptine.
And these drugs can actually shrink the tumor and restore the hormone balance without any invasive surgery. It's a huge victory in endocrine oncology.
Next up, the somatotroph adenomas, the one secreting growth hormone, GH. Now, if this hypersecretion happens in a child before their growth plates have closed, we see gigantism.
But in adults, where the long bones are fused, excess GH causes acromegaly. The bones can't get longer, but the soft tissues and the outer layer of the bones can still grow.
And this leads to really striking physical changes. The hands and feet get larger, the facial features coarsen, a prominent jaw or prognathism. Internal organs swell.
Beyond just the cosmetic changes, the functional problems are severe. Acromegaly patients face a major increase in cardiovascular risk, hypertension, heart failure, and the chronic high GH levels cause profound glucose intolerance. It often mimics severe type 2 diabetes.
And diagnosis relies on finding elevated levels of insulin-like growth factor 1, or IGF-1, which is what mediates most of GH's anabolic effects.
Finally, we have the corticotroph adenomas, secreting ACTH. This is the one that stimulates the adrenal cortex to produce excess cortisol, leading to ACTH-dependent hypercortisolism, which we specifically call Cushing disease.
These are often microadenomas. They can be hard to find on imaging, but they're easy to diagnose functionally. The source also mentions a really fascinating consequence if a patient with Cushing disease has their adrenal glands removed. Nelson syndrome.
Right, so if you remove the adrenal glands, you eliminate the source of cortisol. And that removes the negative feedback on the pituitary.
The brake is gone.
The brake is gone. And without that brake, the small corticotroph adenoma can undergo massive, rapid enlargement. The patient presents with mass effects and this severe hyperpigmentation because the precursor molecule for ACTH also gives rise to melanocyte-stimulating hormone.
That is just a brilliant example of how quickly that delicate feedback system can swing wildly out of control. So, from the master control room, let's follow the signal down the line.
Our next stop is the thyroid gland. the body's engine of metabolism. It's located low in the anterior neck, two lateral lobes connected by an isthmus, and it's made up of millions of these tiny follicles lined by epithelial cells.
And its primary mission is making two hormones, T3, glutathione, and T4, thyroxine. T4 is the main one circulating in the blood, but it gets converted in the peripheral tissues into T3, which is much more biologically active.
And this whole process is orchestrated by the hypothalamic pituitary thyroid, or HPT axis.
Right.
They have a great diagram of this, figure 24.8. TRH from the hypothalamus drives TSH from the pituitary,
Which then acts on the thyroid follicular cells to ramp up T3 and T4 production, and then, of course, the T3 and T4 feedback to suppress TRH and TSH. It's a beautifully sensitive system.
until it's not. When the system goes into metabolic overdrive, we see hyperthyroidism, or thyrotoxicosis. This hypermetabolic state caused by excess T3 and T4 overstimulating almost every single tissue in the body.
And the clinical presentation is profound. It's multisystemic. Patients have heat intolerance, anxiety, a fine tremor, often significant weight loss despite a huge appetite, just because their basal metabolic rate is so high.
The cardiovascular effects are particularly dangerous. Persistent tachycardia, a major risk of atrial fibrillation, which can lead to a stroke.
And the most common cause by a huge margin is Graves' disease. It accounts for about 85% of all cases.
Graves is a classic example of the immune system just misfiring. It's an autoimmune disorder where the body produces autoantibodies, specifically TSH receptor antibodies that don't destroy the thyroid. They actually mimic the action of TSH.
So they're perpetually activating the TSH receptor.
Constantly. It leads to uncontrolled hormone production, completely independent of the body's normal feedback loop. The thermostat is broken, and the furnace is just stuck on high.
Let's get a visual on what that constant, relentless stimulation does to the gland itself. We're looking at figure 24.13. What does a Graves gland look like under the microscope?
So grossly, the whole gland is diffusely and symmetrically enlarged. Microscopically, the follicular epithelial cells are just going wild in response to that TSHR antibody overdrive. They become crowded, tall, columnar, a clear sign of hyperfunction.
They even form these little papillary projections, right?
They do. They fold inward. But crucially, these projections don't have the fibrovascular cores you'd expect to see in a malignant tumor.
And what's happening to the colloid, the stored hormone?
It's being rapidly consumed. So instead of that dense, uniform pink appearance of stored hormone, it looks pale. And you see these characteristic scalloped margins that are called reabsorption vacuoles. You can literally see where the cells are actively pulling the hormone out for immediate release. It's a gland in emergency mode.
And we have to mention the unique features of Graves that go beyond the thyroid, the ophthalmopathy and dermopathy.
They're also linked to those TSH receptor autoantibodies. The characteristic bulging eyes, or exophthalmos, is caused by immune cells invading the tissue behind the eye, causing inflammation and a buildup of these water-binding molecules that make the eye muscles swell.
Okay, let's shift gears to the other side of the coin. Hypothyroidism, a functional derangement leading to deficient hormone synthesis. And we separate primary, which is intrinsic thyroid disease and the vast majority of cases,
From central, which is a failure of the pituitary or hypothalamus, and that's much more rare.
The severity of the symptoms really depends on when it happens. We distinguish between cretinism and myxedema.
Cretinism is what happens when it develops in infancy or early childhood, usually due to maternal iodine deficiency or living in an area where iodine is deficient. The consequences are devastating if it's not caught.
We're talking severe permanent intellectual disability, short stature, coarse facial features.
A complete failure to develop normally, whereas myxedema, which develops later in adults, is more of a profound slowing down of the entire system. Patients exhibit apathy, generalized fatigue, a deep cold intolerance, and that characteristic non-pitting edema.
And that edema is what gives the patient that broad, puffy face. It's caused by the deposition of those same glycosaminoglycans we mentioned earlier, but this time in the subcutaneous tissues.
And in primary hypothyroidism, the lab findings confirm that the feedback loop has failed. The pituitary, sensing low T4, is just screaming at the thyroid. It ramps up TSH relentlessly. So you get a very high TSH paired with a very low free T4.
The most common cause of primary hypothyroidism in places where iodine intake is sufficient is Hashimoto thyroiditis, the most prevalent autoimmune destructive disorder.
The pathogenesis here, which we can see in figure 24.10, really details the immune attack. It's a breakdown of peripheral tolerance that results in this progressive, slow-motion destruction of the thyroid tissue.
It's both T cells and antibodies involved?
It is. You have T-cell-mediated cytotoxicity, where CD8-positive T cells directly attack the follicular cells, and you have antibody-dependent cell-mediated cytotoxicity, using antibodies that target key proteins like thyroglobulin and peroxidase.
The microscopic features of Hashimoto's are one of the most memorable pathology slides we cover. That's figure 24.111. What are the telltale signs of this chronic autoimmune war?
The visual evidence is just. It's stunning. You see this massive, extensive infiltration of the gland by a dense mononuclear inflammatory infiltrate. Lymphocytes, plasma cells, macrophages.
They're everywhere.
Everywhere. The immune cells are so numerous that they often organize themselves into these prominent germinal centers, which is the absolute hallmark of a chronic, ongoing immune reaction happening right inside the gland.
And the cellular change is critical. The presence of Hürthle cells.
Yes. These are metaplastic follicular cells that develop in response to all that chronic injury. They're very large, and they're defined by their abundant, bright, pink eosinophilic cytoplasm, which is just packed with mitochondria. They are the characteristic microscopic signature of long-term Hashimoto's injury.
Before we get to cancer, let's quickly touch on non-neoplastic enlargement. Goiter. A simple goiter is caused by impaired hormone synthesis, often from not enough iodine.
Right, which forces the pituitary to keep secreting TSH, which drives the gland to enlarge in a desperate attempt to normalize T4 levels.
And this diffuse enlargement over time can progress through repeated cycles of TSH-driven hyperplasia and then involution. And that's when you get a multinodular goiter.
Which is irregular, asymmetric, and consists of multiple large, non-uniform nodules. The gross morphology in figure 24.15 shows a dramatically enlarged specimen, often extending down behind the trachea.
And while these are usually benign, they can sometimes become functionally autonomous or, very rarely, harbor a small focus of malignancy.
Now, onto neoplasms. Thyroid adenomas are these solitary benign masses from the follicular epithelium. The single most important diagnostic challenge here is ruling out follicular carcinoma.
And the source material is adamant that the only reliable way to tell the two apart is by examining the capsule. An adenoma is supposed to be completely enclosed in a well-formed capsule.
Exactly. To definitively rule out follicular carcinoma, a pathologist has to meticulously examine the entire capsule of the lesion under the microscope to ensure there is absolutely no evidence of capsular or vascular invasion. If even a tiny cluster of tumor cells breaks through that capsule, it's classified as a carcinoma. That's the fine line between benign and malignant.
Finally, let's get to the most common thyroid malignancy, papillary thyroid carcinoma, or PTC. It accounts for nearly 85% of thyroid cancers in the U.S.
And its molecular underpinnings are very well understood. We have a diagram for this, figure 24.18. The pathways all converge on activating a key growth signal, the MA kinase pathway.
And this can happen either through point mutations, like in the BRAF or RAS genes, or through gene rearrangements, like RET-PTC. The BRAF mutation is particularly common.
This is where pathology really truly shines, because the diagnosis relies heavily on 4 specific critical features, often nuclear features, that we have to visualize to confirm it's malignant. This is from figure 24.1a.
It's incredible. We're diagnosing this cancer based on the specific shape and appearance of the nucleus itself, not just the overall shape of the tumor. The first and most iconic feature is the orphan Annie-I nuclei.
That name comes from the fine, dispersed, washed-out chromatin inside the nucleus. It gives it this empty, pale, ground glass appearance, like the empty eye sockets of the conic strip character. It's a stunning visual.
Second, we look for nuclear grooves and pseudo-inclusions. The grooves are like a deep, linear fold in the nuclear membrane, like a coffee bean, and the pseudo-inclusions are actually bits of cytoplasm that have been folded or wrapped into the nucleus.
Third, while the tumor is named for them, we look for the presence of true branching pubulae, these complex, finger-like structures that have fibrovascular cores.
And fourth, we often find samoma bodies. These are concentric, laminated calcifications, like tiny circular stones often found at the tips of the papillae. They're essentially the sandy residue of dead tumor cells.
Finding any 2 or more of these 4 features, especially those unique nuclear changes, is considered pathognomonic for PTC. But despite the aggressive-sounding name, PTC generally has an excellent prognosis, especially in younger patients. The 10-year survival rate is near 98%.
That is very reassuring. Let's move from the metabolism engine to the guardians of our mineral stores.
Next up, the parathyroid glands, the 4 tiny guardians of calcium. Usually there are 2 superior and 2 inferior glands nestled near the thyroid, and they're composed primarily of these PTH-secreting chief cells.
And their function is beautifully simple. They maintain free or ionized calcium levels in the blood within an incredibly tight range. They operate via a negative feedback loop using these specialized calcium-sensing receptors on the cell surface.
When calcium drops even slightly, PTH secretion ramps up instantly. PTH is the body's main way of raising serum calcium. It does this with a four-pronged attack.
Okay, what are the four?
It increases calcium reabsorption in the kidneys, it increases phosphate excretion in the urine, it increases the synthesis of the active form of vitamin D, and fundamentally, it stimulates osteoclasts to promote bone resorption.
So it's pulling calcium from the bone back into the blood.
Exactly. Now, when this control loop breaks and PTH production becomes autonomous, we get primary hyperparathyroidism. This is the most common cause of clinically silent hypercalcemia, often just caught by accident on routine blood tests.
And the vast majority of cases, something like 80%, are caused by a solitary parathyroid adenoma. Figure 24.25 shows the microscopic view. A well-circumscribed, encapsulated lesion made up almost entirely of these monotonous cheap cells just pumping out PTH relentlessly.
And the crucial diagnostic feature isn't just in the tumor, it's in the tissue around it.
Reading.
Because the adenoma is making PTH on its own, the resulting high calcium levels exert negative feedback on the other three normal parathyroid glands. This often causes them to become compressed and atrophic. So if you see compression or atrophy of the adjacent normal tissue, that strongly points to a solitary adenoma, not diffuse hyperplasia of all four glands.
The clinical consequences of that chronic, persistent hypercalcemia are memorably summarized by the classic triad: painful bones, renal stones, and abdominal groans. Let's break that down.
Painful bones refers to the long-term effects of increased osteoclast activity breaking down the bone matrix. This leads to generalized osteoporosis and these focal bone lesions where bone has been replaced by fibrous tissue.
Renal stones is pretty straightforward. Nephrolithiasis, or kidney stones, caused by too much calcium being excreted.
And abdominal groans covers all the GI disturbances, constipation, nausea, even peptic ulcers, because of how calcium affects smooth muscle and gastric secretion.
And that bone disease can get really severe. Our sources highlight something called osteitis fibrosis cystica. That's in figure 24.26. What exactly is the pathology there?
This is one of the most severe skeletal manifestations. The chronic high PTH levels drive this intense bone resorption, creating actual tunnels and cysts within the bone marrow. These tunnels are lined by osteoclasts, and they lead to extensive marrow fibrosis.
And what about brown tumors?
The severe resorption sites, they often fill up with reactive osteoclasts, giant cells, and hemorrhage. Clinically, they present as these tumor-like masses, which we call brown tumors, just because of the color from all the old blood and hemosiderin.
Beyond this primary cause, we also see secondary hyperparathyroidism. This is a compensatory hyperplasia of all four glands, usually because of chronic hypocalcemia. And the most common driver is chronic renal failure.
It's a total failure cascade. The failing kidneys can't hold on to calcium, and critically, they can't make enough active vitamin D. The resulting persistent low calcium perpetually stimulates all four parathyroid glands to oversecrete PTH, causing them all to get bigger.
It's a correct response, but ultimately a destructive one.
Precisely. And if that secondary hyperplasia goes on for so long that the glands become truly autonomous, pumping out PTH no matter what the calcium level is, that's when it's classified as tertiary hyperparathyroidism.
Usually after the underlying cause, like the kidney failure, has been fixed, say, by a transplant.
Exactly. Even though the calcium regulatory inputs are now normal, the enlarged parathyroid glands just stay hyperactive, leading to persistent hypercalcemia.
We've covered the structural and metabolic regulators. Now for what is probably the most widespread metabolic disease on the planet: diabetes.
We're shifting now to the endocrine pancreas, specifically the islets of Langerhans. These are the specialized clusters of cells embedded within the exocrine or digestive part of the pancreas.
The islets have four main cell types, each regulating glucose differently. We're going to focus on the beta cells, which are the most numerous and secrete insulin, and the alpha cells, which secrete glucagon.
Insulin's job is fundamentally anabolic. It promotes the uptake of glucose by almost all cells, especially muscle and fat, and it promotes the synthesis of fat, protein, and glycogen. Its net effect is to lower blood glucose.
And glucagon has the opposite effect. It raises blood glucose.
The disease state here is diabetes mellitus, or DM, which is characterized by chronic hyperglycemia from defects in insulin secretion, insulin action, or both. The scale of this public health crisis is just staggering, over 422 million people globally.
And the chronic consequences make it a leading cause of end-stage renal disease, adult-onset blindness, and non-traumatic lower extremity amputations in the U.S.
Diagnosis is pretty straightforward. It relies on thresholds like a fasting plasma glucose of 126 mg/dL or higher, or at HbA1c, which is a glycated hemoglobin, of 6.5% or more. That HbA1c value gives clinicians a long-term average picture of glucose control of the last few months.
Let's spend some time separating the two main types, starting with type 1 diabetes, or T1D. This accounts for about 5 to 10% of cases, and the mechanism is an absolute deficiency of insulin.
The pathogenesis is purely autoimmune destruction of those insulin-producing beta cells. It's a progressive stage process, which is outlined in Figure 24.31. Stage 1 is asymptomatic. You can detect the autoimmunity, say, with autoantibodies, but the beta cell function is still normal.
Then in stage 2, you move to pre-symptomatic dysglycemia. The impaired glucose tolerance begins to show up.
And finally, stage 3 is the clinical onset. By this point, over 80 to 90% of beta cell function has been lost. This leads to absolute beta cell failure and the need for immediate insulin replacement therapy for survival.
Pathologically, what's the visual evidence of this autoimmune attack?
We look for something called insulitis. That's Figure 24.35. It's a mononuclear inflammatory infiltrate, mainly T lymphocytes, that you can see right inside the eyelids of Langerhans, directly targeting and destroying the beta cells. It's the hallmark of the active disease process.
Type 2 diabetes, T2D, however, is a much larger and mechanistically more complex problem, 90 to 95% of cases. It's defined by a dual defect: insulin resistance combined with beta cell dysfunction.
Insulin resistance just means the peripheral tissues, muscle, liver, fat, they fail to respond appropriately to the insulin signal. They stop taking up glucose sufficiently.
Figure 24.32 traces this progression perfectly. Insulin resistance, which is often intimately linked to obesity, forces the beta cells to compensate by massively increasing their insulin output. This is called hyperinsulinemia. They're just working overtime to keep glucose levels normal.
But that compensation eventually fails. The beta cells succumb to exhaustion and dysfunction. Their ability to secrete enough insulin decreases, and you get decreased insulin secretion, persistent hyperglycemia, and then clinical T2D. It's a metabolic death spiral.
We need to elaborate on the role of obesity here. We're not just talking about mass, we're talking about the specific endocrine function of visceral fat.
Exactly. Excess visceral fat tissue acts as its own endocrine organ. It releases large amounts of free fatty acids and inflammatory hormones called adipokines. And these circulating FFAs and adipokines actively promote insulin resistance in the liver and muscle.
And on top of that, the chronic exposure to high glucose levels, something called glycotoxicity, is directly toxic to the remaining beta cells, which just accelerates their failure.
When insulin deficiency becomes severe, the acute metabolic complications are catastrophic. For T1D, the onset is often defined by a classic triad of symptoms.
We call them the Ds: polyuria, polydipsia, and polyphagia.
So the high glucose levels exceed the kidney's ability to reabsorb it. Glucose spills into the urine, and it drags massive amounts of water with it. That's osmotic diuresis, or polyuria.
The resulting volume depletion triggers intense thirst, polydipsia. And the constant hunger, polyphagia, comes from the fact that without insulin, the body is in a profound catabolic state. It can't use glucose for energy, so it's constantly signaling that it's starving.
Figure 24.33 illustrates the metabolic derangement that can lead to a diabetic coma in T1D. Severe insulin deficiency causes two huge problems at the same time. Decreased tissue glucose, use A and D, a massive increase in the breakdown of stored fat cell polysis.
And what happens to all those free fatty acids?
They get shunted to the liver, where they're converted into ketone bodies. This process overwhelms the body's buffering capacity, resulting in diabetic ketoacidosis, or DKA, a life-threatening metabolic acidosis where the blood pH plummets.
And at the same time, the lack of insulin means the liver's just pumping out more glucose, which makes the hyperglycemia even worse. The volume loss, the hyperosmolarity, the acidosis, it culminates in a diabetic coma if there isn't rapid intervention.
While DKA is acute, it's the long-term damage, the chronic complications, that make diabetes so destructive to a person's quality of life. Persistent chronic hyperglycemia drives what we call glycemic toxicity.
And that's mediated primarily by two pathways.
First, the formation of advanced glycation end products, or AGs. Glucose binds irreversibly to proteins of the blood vessel walls and tissues, making them stiff and alter their function. Second, the chronic metabolic stress activates the protein kinase C pathway, which drives pro-inflammatory and procoagulant changes.
Figure 24.34 is a terrifying map of the full scope of this long-term damage across the entire body. The effects are systemic.
We see severe microangiopathy, damage to small vessels, and macroangiopathy, damage to large vessels. In the brain, microangiopathy increases stroke risk. In the eye, retinopathy is the leading cause of adult-onset blindness.
Cardiovascular damage is hugely accelerated. Severe atherosclerosis, heart attacks, congestive heart failure. Diabetics have a 2 to 4 times greater incidence of heart attacks than non-diabetics.
And the kidney failure is profound. Diabetic nephropathy is the leading cause of end-stage renal disease in the U.S. Finally, peripheral neuropathy affects 60 to 70% of long-term patients. It leads to loss of sensation and motor function, creating the perfect environment for non-healing wounds and eventually amputation.
Let's focus on the pathology of diabetic nephropathy because the microscopic changes are so specific and they really demonstrate that architectural damage. The diffuse thickening of the glomerular basement membranes, the GBM, is the microscopic hallmark of diabetic microangiopathy.
This basement membrane thickening is widespread. You can see it in capillaries of the skin, skeletal muscle, the retina, but it's most consequential in the kidney. Our sources highlight 3 major lesions here from figure 24.39.
First is diffuse mesangial sclerosis, which is an increase in the mesangial matrix throughout the entire glomerulus.
Second, and this is the truly pathognomonic lesion, nodular glomerulosclerosis or Kimmel-Steele-Wilson lesions. These are distinctive oval or spherical laminated nodules found mainly in the periphery of the glomerulus. They represent a severe accumulation of mesangial matrix that obliterates the capillary loops. When a pathologist sees these, the diagnosis is confirmed.
And third, the larger vessels suffer from widespread renal atherosclerosis and arteriolosclerosis, specifically hyaline arteriolosclerosis, where the walls of the small arterioles become thick and glassy, contributing to hypertension and renal ischemia.
The electron micrographs in the source material, figures 24.37 and 24.38, they really bring this home. You can visually confirm that pronounced widespread thickening of the GBM. This isn't just a functional failure. It's a fundamental structural transformation driven by chronic high blood sugar.
It perfectly illustrates why diabetes is often considered a disease of the vasculature of connectivity, all caused by a breakdown in chemical signaling. Okay, for our final system, the regulators of stress and salt balance.
We conclude with the adrenal glands, which sit like little hats on top of the kidneys. They're divided into the outer cortex, which makes steroid hormones, and the inner medulla, which makes catecholamines like epinephrine.
And the adrenal cortex is anatomically organized into 3 distinct zones, each responsible for specific steroid production. The zona glomerulosa makes mineralocorticoids, primarily aldosterone, which regulates salt and water balance and is controlled by angiotensin II.
The large middle layer, the zona fasciculata, makes glucocorticoids, primarily cortisol, our main stress hormone, which is regulated by ACTH. And the inner layer, the zona reticularis, makes sex steroids or androgens, also regulated by ACTH.
When we have excess cortisol, we enter the realm of hypercortisolism or Cushing syndrome. This can be due to external steroid use iatrogenic, which is the most common cause, or from endogenous overproduction.
And endogenous Cushing syndrome is classified by whether it's ACTH dependent or not. If it's caused by an ACTH-secreting pituitary adenoma, that is specifically Cushing disease.
ACTH dependent.
Right. If it's caused by a primary adrenal tumor, an adenoma or carcinoma, that is ACTH independent.
The clinical presentation is highly characteristic, resulting directly from the actions of too much cortisol. That's figure 24.44. What are the telltale physical signs?
Cortisol promotes fat redistribution and protein catabolism. This leads to central obesity, a rounded face or moon phases, and fat deposition on the posterior neck, the buffalo hump.
And the catabolic effects break down collagen. That's what causes the skin to become fragile and leads to those wide, reddish-purple cutaneous striae or stretch marks, especially on the abdomen.
Furthermore, the excess cortisol causes a selective atrophy of the fast-twitch muscle fibers, resulting in pronounced muscle weakness. It also suppresses the immune system and promotes osteoporosis.
Diagnosis relies on proving the hypercortisolism is sustained, using things like a 24-hour urine-free cortisol concentration. Then you use the dexamethasone suppression test to try and locate the source.
Shifting to the mineralocorticoid side, we look at primary hyperaldosteronism, or CON syndrome, chronic excess aldosterone production.
Aldosterone's primary job is to retain sodium and excrete potassium and hydrogen ions. So chronic excess leads to sodium retention, which means volume expansion and significant potassium excretion, or hypokalemia.
The etiology is split. About 30% are caused by a solitary aldosterone-producing adenoma, while 60% are due to bilateral idiopathic adrenal hyperplasia.
And the clinical impact is massive. Conn syndrome is one of the most common causes of secondary hypertension. The hypokalemia from all that potassium excretion can cause severe muscle weakness and cramping.
The regulatory loop, which is in figure 24.45, provides the necessary diagnostic distinction. Since the aldosterone is being produced autonomously, it causes volume retention, which suppresses the renin-angiotensin system.
So the diagnostic signature of primary hyperaldosteronism is the combination of high aldosterone levels paired with low plasma renin levels.
That is the key difference from secondary hyperaldosteronism, where both renin and aldosterone would be high, usually in response to true volume depletion or decreased blood flow to the kidneys.
That distinction really underscores our entire theme today. Understanding the mechanism of the feedback loop tells you exactly where the problem originates, whether it's a stuck switch, an autoimmune attack, or an autonomous tumor.
We have journeyed through 5 major endocrine organs, and the synthesis is so clear. The complexity of this system is manageable once you understand the regulatory loops. Disease, whether it's Graves', Cushing, or type 2 diabetes, almost always presents as a catastrophic breakdown in these crucial feedback mechanisms.
A broken thermostat, an immune attack, a jammed throttle.
Exactly.
Absolutely. And reviewing our aha moments, the most scientifically and visually striking details are those specific microscopic signatures we talked about, the ones that confirm the underlying pathology. This is the visual language of disease.
Just think about the cellular scaffolding, that reticulin network, being completely absent in a pituitary adenoma, which confirms that pathological proliferation. Or the evidence of a chronic battle in Hashimoto's. The masked immune cells forming germinal centers and the development of those distinctive mitochondrial-rich Hürthl cells.
And the specific markers that define malignancy, like those 4 unique nuclear features in papillary thyroid carcinoma, especially the clear, empty appearance of the orphan Ani nuclei.
And on the metabolic front, seeing the definitive architectural damage of chronic hyperglycemia in the kidney, which is just epitomized by those oval laminated nodules of the Kimmel-Steele-Wilson lesions.
We've seen how these small changes at the cellular or genetic level, like that single mutation in the GNase protein that creates a sustained on switch, or the targeted specific autoimmune attack on the pancreatic beta cells in type 1 diabetes, can completely redefine the body's internal state.
With long-term systemic consequences that just ripple through every single organ.
Which brings us to our final provocative thought for you to explore. We focused heavily today on the profound influence of metabolic and stress hormones like cortisol, thyroid hormone, and insulin on physical health. But considering how intricately the HPA axis, our stress response, and the thyroid axis govern energy and mood, what largely unexplored connections exist between chronic, long-term, and perhaps even subclinical endocrine dysfunction and our overall mental, emotional, and neurocognitive health.
It's a question of how much that chemical equilibrium dictates not just our physical stamina, but our capacity for focus, for resilience, our general sense of well-being. The body is always talking to the brain.
A truly integrated system indeed. Thank you for joining us for this deep dive into decoding text and tissue. We'll see you next time.